Welcome to Dr. CM Edcast, your go-to resource for medical learning. Through discussions, case studies, tutorials, and debates, we help you learn, grow, serve.
Welcome. In this explainer, we're going to dive deep into the pharmacological management of acute respiratory distress syndrome, or ARS. We'll focus on the core drug classes, how they work, and where they fit into the overall clinical strategy. This is the high-yield information you'll need for your exams and for understanding patient care. So before we can treat ARDS, we have to know exactly what we're up against. At its core, ARDS is a widespread inflammatory attack on the lungs. The key problem is that the blood vessels in the lungs become leaky. This allows protein-rich fluid to flood the air sacs, or alveoli, causing what we call pulmonary edema. This fluid gets in the way of gas exchange, leading to dangerously low oxygen levels, or severe hypoxemia. Now, what kicks this whole process off? Well, the triggers can be either direct hits to the lung, like pneumonia or aspirating stomach contents, or indirect insults. Things like sepsis or major trauma can set off a massive body-wide inflammatory response. But here's the key. No matter what the initial trigger is, the final common pathway is the same. It's a storm of pro-inflammatory cytokines that damages that delicate barrier between the alveoli and the capillaries. Here's our game plan. We'll quickly recap our treatment goals, then we'll break down the drugs that target inflammation and improve lung function. After that, we'll cover the crucial supportive care, and we'll wrap up with some key clinical pearls to tie it all together. Okay, before we get into specific drug names, let's establish our strategy. When we have a patient with ARDS, what are we actually trying to accomplish with our medications? The goals really boil down to three main things. First, and most importantly, we have to get that underlying inflammation under control to stop any more damage to the lungs. Second, we need to do what we can to improve lung mechanics, to make breathing easier and get oxygen levels up. And third, we have to prevent all the other bad things that can happen when someone is this critically ill, like blood clots and secondary infections. Let's start with that first objective, targeting the out-of-control inflammation. The whole point of the drugs in this section is to dial back that destructive inflammatory cascade. The primary drug class we use here is the corticosteroids, with methylprednisolone being a classic prototype. So how do they work? They get inside the cell, bind to glucocorticoid receptors, and this whole complex travels to the nucleus. There it acts like a director, telling the cell to stop producing pro-inflammatory cytokines like TNF-alpha. Now their use in ARDS are still debated, but you'll often see them considered in the early severe phases to try and blunt that cytokine storm. Of course, you have to watch for adverse effects like high blood sugar and immunosuppression. And a quick historical pearl for exams. Activated protein C was once used, but it was pulled from the market because of bleeding risks and a lack of clear benefit. All right, so we're trying to manage the inflammation, but at the same time, we need to use therapies that directly help the lungs do their job. So the question becomes, how can we pharmacologically make ventilation and perfusion better? We've got a few tools in the toolbox here. First, there are pulmonary vasodilators, like inhaled nitric oxide and prostacyclins. These drugs work to selectively open up the blood vessels in the lungs. This is great because it lowers the pressure in the pulmonary arteries and helps shunt blood toward the parts of the lung that are actually getting oxygen. We might also use bronchodilators like salbutamol if there's airway tightening. And finally, surfactant therapy has been explored. The idea is to replace the natural surfactant that gets washed out by all that edema fluid, but its benefit in adults is still a bit controversial. Let's zoom in on the mechanism for inhaled nitric oxide, because this is a really elegant and very high-yield pathway. Because it's inhaled, the drug goes right to the air sacs and diffuses into the smooth muscle of the blood vessels nearby. Once inside, it flips the switch on an enzyme called guanylate cyclase. This enzyme then starts cranking out a molecule called cyclic GMP, or cGMP. And what does cGMP do? It tells the smooth muscle to relax, causing potent vasodilation right where we need it. This selectivity is the magic here. It improves blood flow to the parts of the lung that are working, which boosts oxygenation. You know, ARDS doesn't happen in a bubble. The patient is critically ill, and we have to manage everything else that's going on in the body. This supportive care is every bit as important as the therapies aimed right at the lungs. Supportive care is absolutely crucial. To manage fluid overload, we often use loop diuretics like furosemide to help the kidneys pull off extra fluid. To maintain blood pressure and ensure the organs get enough blood, we use vasopressors, with noradrenaline usually being the first choice. It acts on alpha-1 receptors to constrict blood vessels and get that mean arterial pressure up to our target of 65 or higher. Prophylactic anticoagulants like heparin are also standard procedure to prevent dangerous blood clots. And of course, if an infection like sepsis is what caused the ARDS in the first place, we have to hit it hard with the right antimicrobials. Okay, let's bring it all home. Let's distill all this information down into the key takeaways that will guide you in practice. So if you remember one thing, let it be this. There is no single recipe for treating ARDS. Therapy has to be tailored to the individual patient. You have to consider what caused the ARDS, how sick the patient is, what other medical problems they have, and most importantly, you have to constantly reevaluate how they're responding to your treatments. And that brings us to a final thought exercise to really cement these concepts. Think about two different patients. One has ARDS because of sepsis, the other from a major trauma. How would your drug choices differ? For the patient with sepsis, getting the right antibiotics on board immediately is the top priority. For the trauma patient, you might be thinking more about pain control and managing that systemic inflammatory response from the injury itself. Being able to answer that question shows you've really grasped the principles we've covered today.